but we'll see if we can get them in. The main thing is, I suppose the other part of this is we're recording this session, which is really important. The link is going out again while you're on, so we'll see if we can try and remedy that. But from our side, I need to apologise on our behalf for that, because there was a glitch with it. So we are less guests than usual joining us this morning, which is a pity because we're bringing it all together. But what I think we might do, if it's okay with you, is actually send this particular recording out after you finish today, straight away, rather than putting it up online and doing it, waiting for the full suite. I think what we'll do is send this out particularly to the list that Anya has today of all the people that have been on this programme, because this is the culmination of a wonderful 3 weeks. We've had fantastic feedback, even back into the office again this week. So despite all and today's glitches, the interest is hugely there. I think there's something about this particular programme that we need to kind of look at again, I think, going into the new year, because people are anxious. I had somebody yesterday call me actually that said, can I have last week's recording, even though she was on? She wanted it again. So something I put up in our practice, and I hadn't given it. As you know, I put up your recordings at the end usually, but what I think I might do is, in consultation with Catherine and yourselves and Anya, is maybe send these out to the people that have been attending specifically initially, and then put it up culmination, because it's very current, it's very evident, and people are using it right now. So what's the point in kind of holding back, as they say,
Yeah, that's okay.
I've got a buzz since you started, or whether it's you started recording or started speaking. I've had a buzz, which has just stopped now that I'm talking, and you've stopped talking. Are you getting that, Angela?
Little bit of feedback, small amount, Stop now.
I'll stop talking anyway shortly in a minute.
Just more be irritating on the recording, I'm thinking, for them.
Sure, exactly. We'll see.
Yes, it's a sound.
I don't hear a buzz your side, I have to say.
As I say, it's only when you're talking, so hopefully it'll stop then.
Okay, anyway. It could be my mic.
Your sound, Aisling. I think it's coming from your mic, actually. Yeah.
Anyway. Well, I'll stop buzzing. But the other thing I wanted to mention to you also is, and thanks, Angela, I noticed Anya had said that she would circulate 2 of the documents that I had just come across, and it was just, it's just, I just think it's another piece of, I suppose, connectivity to where we're at in terms of this. Absolutely. So without further ado, I'll introduce, because of my sound and also because I'm here anyway for the duration of this morning. I'll introduce Dr. Angela Colkman and indeed Dr. Sheila Wickham for this 3rd and final piece of this particular series of our autumn-winter webinar with the Ursula P&A College. And this part is bringing it all together in terms of the physical illness piece and the screening with mental illness, and the MEC, which has become hugely topical, I noticed, throughout each of the 3 webinars we've had. The MEC is the new lingo. I think I've learned about MEC. I knew nothing about MEC, I have to be honest, and people are now asking about MEC. So it's obviously a very useful tool. It's obviously a stalwart, as it were, as Angela puts it, and I think in this final piece we will put it together, but I think for the future, coming into the winter spring, we might look at a little bit more of it in this whole area, because, as I said, thanks to Angela, Sheila, Anya and Catherine, this particular series has been really popular. So thank you all, and over to you. I'll go on mute just for now.
Okay, good morning, everybody. You know me, Angela Colkman, and my colleague Sheila will take over in 2 minutes. I'll just welcome you all again to listening to this. Some of you might be having this live, and if not, if it's pre-recorded, I hope you're able to stick with us for the next hour or so, and we'll go through what we've been talking about for the last number of weeks. We'll start by, sorry, forgive me.
Sheila. It's just on share and share again, Angela.
Sorry,
that should resolve it.
Because it wasn't okay for you.
Something went wrong immediately the very minute I went to open the slides. Forgive me. This looks like might have. Yeah. Okay, we're back again. All right. Sorry about that, everybody. Yeah, when we say recap from last week, we're really continuing on in the whole area of chronic illnesses and particularly looking at metabolic syndrome. We have Dr. Sheila Whitcomb, who specialises in the care of diabetes, and a lot of work has been done on her behalf around health promotion as well and screening. So today we're going to continue on that theme and talk about the benefits of screening, both for metabolic syndrome and the national screening programs. And you're right, we do talk a good bit about making every contact count, because that's where we do our intervention with our clients. So we will speak about that, and we're going to try and just cover as much as we can today to bring it all together for you about what we've been talking about for the last 2 weeks. So Sheila's going to start out and just recap about what we were talking about chronic illness. So over to you, Sheila.
Thank you very much, Angela. And as I say, I'll start this off and then I'll hand over to Angela. Now, as you know, over the last 2 weeks, we've been talking about mental illness and physical health and the importance of both, and particularly focused on chronic illness. As I say, I talk a lot about diabetes. We've also mentioned COVID, and it's the one thing I would say now. We had a healthcare system. It wasn't perfect, but in fairness, it was working. You know, it did manage. We needed to improve various elements of it. Having a pandemic for the last 18 months, 20 months, nearly 2 years next March, has had a huge impact on our health care. There's no way we can avoid that. And it's something we have to now build into everything we do. And Angela will mention this in MEC, and I would certainly mention it in relation to screening, where I lost a lot of my screening programs for a period because we just shut down. Now, that doesn't mean that the people weren't getting the illnesses, or that it just means they weren't being screened for them, and therefore diagnosis was quite often later. So it's something we now have to remember. And as I say, there was issues with normal healthy people who weren't screened. We even have more issues now when you consider your clients, your patients with mental illness who missed screening opportunities. They miss enough of them anyway because of the nature of their lifestyle and their various other complications and the diagnostic overshadowing in that, which Angela has spoken about. So it's all the more important. You need to keep this in mind now for your clients and your patients to do it. As I say, if you get your chronic disease, it has a huge, potentially huge impact on life, as you will know with all your clients, because they do have a chronic disease. Serious mental illness doesn't tend to go away. You can have a gradual onset in some, not always. Most chronic diseases can be progressive. So it's something to remember as well, because it's something particularly I always came across in diabetes care, which is a progressive disease. And patients would get very frustrated when they've been doing everything right, taking their medication, which had worked for a long period. But then as the disease progressed, they needed more, and they felt it was sometimes their fault. And indeed, the health professionals sometimes blamed them, which was incorrect. So it's something to remember. The impact of a long-term chronic illness on your quality of life can be extremely harsh at times. So it's something to remember that we need to try and prevent it, delay it as much as possible. The older you get, the more likely you are to have a chronic disease, indeed, the more likely you are to have multiple chronic diseases. And as I say, if you're starting with mental health illness to begin with, and then I start adding on these physical illnesses, it will have a serious impact on their quality of life. And that's what we want to do, is avoid those things. The next I want to talk about is Healthy Ireland, which we did start this. Now, you'll have seen, again, this went on the shelf for a while. You'll now see that the couch and Joe are now dancing across your TV screens if you happen to see the ads. But Healthy Ireland was our plan to keep to get the country moving and get them active. And the reason they started was because of the rise in chronic illness. As a population, we're getting a bit older anyway. We know that from all the screaming about the pensions. So as a result, chronic disease is rising in Ireland. It's interesting, they don't focus on people with mental illness as a particular cohort. They mention mental health, but not particularly focusing on those within that mental illness cohort. So it is something to remember. Just because your patients have mental illness doesn't mean they don't get everything else and are prone to everything else. And that's what we really want to emphasize on this. They're just people who need to be looked after, who need to have health promotion, who need to have screening, who need to have MEC. And that's what we want. And these are the stats and the reason why. Alcohol consumption highs in Ireland. That contributes to my obesity. one of 5 children are obese. Increase in cancers, that's to do with our lifestyle as well. Now, as I say, we could give you a whole session on any of these topics, but you're lucky you're not going to get them from us today. But it is something, there's certainly more out there, and there is various good places to pick it up on. And I would recommend that you try and keep in touch with them. And again, use the preventive measures such as the screening. I also wanted to mention Sláinte Care. These are the policies we are putting in place to actually try and do something to make sure we don't go down the serious chronic illness route with an abundance of people with chronic illness. And to do this, Sláinte Care started in 2017. And again, I put it in deliberately because we have heard a lot about it very recently. Infrastructure, primary care, integrated care, which is a very important part. And this would hopefully, if we could develop it, and they are trying, this would help alleviate the fact that we all tend to work in parallel. Because by integrated care, it would mean that those looking after my mental illness would talk to the people who look after my physical illness, and this would be the who talk to the GP, Again, the aim is to improve funding and ideally get rid of our 2-tier system. But we've had a few problems with healthcare, with Sláinte Care. And it's just on the next slide, we see it came into the news recently. Just the next slide there, Angela. The Sláinte Care, yeah. For various reasons, a number of people retired or resigned because they said it wasn't happening fast enough. Now, again, there's something I was just talking to Aisling about before we started. If you look at where we were at this time 2 years ago, I didn't have a large number of healthcare professionals, never mind the admin and everybody else, working as swabbers, as vaccinators, and all this. Where do you think these people would come from? Now, some of them certainly would be older people who came out of retirement or something like that. But and I've done vaccinations, it's quite interesting. There are a reasonable number, and I'd say maybe at least 40%, who have come from healthcare settings, such as hospitals and that, who have had enough there and they wanted to get away and they like the vaccinations or they're happy to do the swabbing. You think of the impact that's going to have on my ability to deliver anything within healthcare, any innovation, aside from the fact, and you all know everybody is burnt out. There's no staff at the moment. So it's causing huge problems for us, and it's something to remember. There have been some progress with Sláinte Care, but there's a long way to go. As I say, we did publish our action plan in 2019 and it is available. You can have a look at it. Unfortunately, we are not getting there as fast as I'd like at all. So,
yeah.
But it is, as I say, we had Healthy Ireland, we had Sláinte Care, we're making every contact count. I'm not going to say much about this other than the fact, again, it's based on the idea that I'd interact with my patients, particularly when I'd meet them. How many of us are meeting our patients on a regular basis lately? Not enough of us, and certainly with the pressure people are under, if they meet their GP and that, the chances of them stopping, I know it only takes literally seconds, but the chances of it happening are much reduced at the moment. A lot of even the GP consultations are being done on Zoom, which doesn't give you the same atmosphere for having a chat with them. By right, we should all be trained on it, but I also know that the training for the MEC has been not quite suspended. People didn't have time to do it and they didn't have time to deliver it.
Yeah.
The prevention and management of chronic disease is based on all our policies that we've been developing, and the idea of bringing it all together and particularly making it happen so that we would work together and ideally prevent the problem. Should the problem be there, we'll delay it by looking after people well. And that's where, and I wanted to mention the integrated care program particularly. It's the next one there, Angela.
Yeah.
This is the whole idea, and it's why it's so important with it. It's the whole idea. We need to aim up, join up our healthcare and indeed our social services and utilize everything that we have. And you know that yourself. You can do very well with your client or your patient, and you've got them well established on their program of care, and they're perhaps attending every week or every fortnight or whatever at the regular, and things are developing well. But then you find that they're living in very unsuitable conditions. And yet to link up with social care services to improve their living conditions, to try and maintain all you've got, all the progress you've made with their mental health, can be very, very frustrating. And this is why it's so important that we do get our integrated care and we work together. You know yourself, and it's particularly relevant when I get started with the screening. We miss the people with mental illness for screening because they don't always have stable backgrounds. They're not always at the addresses they initially registered with and such like, and it does cause us problems. As I say, we're looking at particularly 4 integrated care programs: older people, children, patient flow. You'll notice there's no specific area for mental illness, but prevention and management of chronic disease, which I argue both the older people, patient flow, and my chronic disease, which is my focus, that automatically includes your clients or patients. But the thing is, sometimes we have to shout loudly so that they're included in it. And that I would say to you. So I'm going to talk a little bit about the screening service that we have available in Ireland. And then I'll hand over to Angela. We have breast check, cervical check, bowel screen, and the diabetic retinal screen. It's interesting. If you ask people, and I'm talking about my student nurses and indeed my postgrad sometimes, what screening is available in Ireland, they'll know about breast check and cervical check. The odd one knows about bowel screen, but not a lot of them. But the diabetic retinal screen is unknown to most of them. They've all been up and running for a number of years. I appreciate we did suspend some of them now last year. But the thing about this is we spoke last week about the problems your clients have. You are more likely to get bowel cancer if you are obese and overweight. A lot of your clients are. We've already talked about the MET syndrome. A lot of your clients have diabetes. They should be using these. They should be automatically on them. And again, we have the research which shows they have a poor attendance at national screening programs. This is where they need us. They need us to scream and shout and push for it and encourage them. And indeed, it will be something I would include in MEC if I had my way, but I don't think I'll get to reorganize it now. Have you been screened? You know, it should be a simple question to ask. We look at why we screen. We screen to diagnose, to test or monitor disease, to treat it. Ideally, they should be effective and they should be clinically, socially, and ethically acceptable. And that's something to think about. Shall I screen for diseases I can't cure? You know, we had, when HIV came in, that was quite a challenge as to who we screened for, and there was ethical reasons to screen. It certainly wasn't socially acceptable, and there's always this with illnesses as well. At the moment, we have 4 national programs, though, and these are the ones I'm going to talk about. There are benefits to it. If I diagnose you early, look at the 4 I've mentioned there. If I diagnose you early, you have a much better prognosis. Usually you'll require less radical treatment and people are reassured. We've got a, you know, there is disadvantages. Now no screening is 100% accurate, and it's not 100% accurate for various reasons. If you look at the problems we have had with our cervical screening, there's been huge problems with that. Breast screening, on occasions we've had a few, but not as major as the cervical screening. So you know, it's not perfect, and that's what people always need to remember. And unfortunately, as long as we keep involving people, human error, unfortunately, will always occur. It can lead to unnecessary worry and further investigation sometimes. We are on the side of caution, and if in doubt, we do tend to be proactive. So people can then have a week or 2 of hanging in there going, is that lump? Is it? Now, in fairness, they've improved it. You tend to go in and have your scan and your biopsy and all that together now for it. But even that will wait a few longer, can wait a while. When I finally diagnose this, and bear in mind, I'm now diagnosing people who, in an ideal world, should have been diagnosed last year if we'd been running our screening programs fully. So now, when they're diagnosed, is there any change? Is there any, you know, where do I stand with that? And now do they just have the illness and now they know earlier? And is that a benefit? Question. So nothing is perfect, but I do think you know, the pros outweigh the cons of it. Each program has an individual register. It is something which, again, ideally you get your clients to do this, but that varies on their ability, their access to computers, on all this lark. Well, there is a free phone number. In an ideal world, we'd have someone else to do it for those who can't do it. But certainly some of your clients could. And I would always say the more proactive and encouraging you can be to allow people to look after their own health, the more involved they get, the more likely they are to stay, to work with it. So, as I say, ideally check. Breast check, most commonly diagnosed cancer of women. Skin cancer, by the way, is most commonly diagnosed cancer in Ireland. We have about 3,700 every year. It has a very good prognosis by and large if we diagnose early. I can just move on there. We give a mammogram every 2 years to look for breast cancer. But no, they have improved. I remember at one stage a few years ago talking to them, they had a 50% DNA rate. So it's something to remember. And it's something, again, this word, like, have your clients been for their breast check? Have they been called for it?
Yeah.
Did they go? Yeah. Cervical check. This starts quite early, and not everybody is aware of this. It starts at 25. So again, this is where it's general health promotion information you want to tell them. Free smear, like a cell sample. We now check for HPV. That's the first thing we check for on this sample. And ideally, with our HPV vaccination rolling out and our uptake is improving dramatically, if you look at the figures from Australia now, they have nearly wiped it out. They give both girls and boys in school get it. And did anybody see that paper, which I haven't circulated, the paper from the UK recently, which talked about the major reduction in it since they have started their HPV testing and HPV vaccine, rather. It has made a dramatic difference. So again, it's something to make sure happens. Have they been screening? It's a bit more invasive. Patients aren't as good about going for it. Again, you mightn't always have, your clients mightn't always have a good relationship with their GPs. Sometimes they might turn up or not even turn up for their things, and that's it. So they're the figures, and that's when you should have it. As I say, the information is readily available. Bowel screen is the next one I want to mention. And bowel screen, as I say, second most common cancer in men, third in women. As I say, you can start with skin, and with men, then the next is bowel. With women, it's breast and then bowel. We lose a phenomenal amount of people to this every year. And this, again, if you get it early, is preventable. So we have started to screen for it. And if you look at the next, what we do, this is a simple home test. Now, again, it got slightly interrupted because the people who do, when people have to send in a small sample of stool into a sealed container in an envelope and post it off. You get it, once you're prepared to engage with it, you get it out. They'll post it out to you. Think of your clients. How many of them, one, where are they? Have they a steady address that they can commit to this? How many would engage with this? How many could do it? So these are all factors. Then the fact that I took half the lab staff away from things like analysis on routine stuff to have them analysing other things, swabs for COVID and such like, has slowed us down, but it is getting up and running again. So it's something, again, it's, if you get it early, then we can prevent major problems. We can prevent them having the ileostomies or the colostomies. We can allow them to have much better quality of life. So it's a simple thing, it's readily available, and ideally, how many of you would ever have asked a client, have they ever had it? Have they ever done a bowel screen? And these are things we should be doing regularly. Every 2 years, simple home test, and it could be done. So, and finally, my last screening, the national screening program, is a diabetic retinal screen. From the age of 12, if you have diabetes, be it type 1 or type 2, you're entitled to a retinal picture. It's, if you get diabetic retinopathy, if we get it early, what we actually do is you get leakage and such like an little aneurysms in the small vessels at the back of the eye. And if we get it early, we can seal those off. We'll actually seal them off cauterization. Works very well if we get it early enough. And we do it every 12 months or more frequently if needed with it. It is a huge problem. It causes blindness. Now, again, your clients have enough on their plate. They don't need to have, and if you look at the next slide, this is what the diabetic retinopathy would do for you. Could you imagine the psychological impact of that? If this is what happens, and if we're at that advanced stage, if we get it at stage 3 or 4, we can't do much. We can try and slow it down, but that's about the height of it. So the next thing which I said I couldn't possibly go through, whether you call this a national screening program at the moment or not, is COVID screening. And the reason I put this in, one, because it's unfortunately impacting on all aspects of our life at the moment. Most of us, because we work in healthcare, will have had a COVID test at some stage, at least one. So it's something we're conscious of and aware of. And there are various ways of screening for COVID. The antibody is gold standard. I'll take your blood, see what level of antibodies you have, grand. Zero. The PCR test is the most common one which we do when you can get an appointment. And as you know, there's huge issues about this at the moment. It's interesting. They keep talking about setting up walk-in centres. I'm just curious, who's going to staff the walk-in centres? We actually need to train swabbers before we let them loose. I need them to be able to do it properly. I need to have the whole support line, and that goes from admin staff, security staff, stewarding staff around the centres, cleaning staff, people to analyse the swabs when I get them. There's a whole, the contact tracers. It's not as simple as throwing up a thing, so it's something to remember. The antigen tests, which are quite easy, relatively speaking, and we were just talking about this before we started. Has anyone tried to do one of their own? It's not that easy. Well, it depends how you are. Some of us aren't now. Or even to try to do it to a child. If it's not done correctly, it's much easier to get a false negative on an antigen test than to get a positive. Very easy to get a false negative. So unless it's done correctly, it's a waste of time. Look at your clients, how many of them would be capable of doing that correctly. And that's something to remember. So, the people will also do it that they want the security of knowing they're negative, but they haven't done it properly. So it's a false sense of security, and it's something to bear in mind. The temperature check, which is, I know I've seen it in use, but most people have dropped it. It's not very effective. It's a waste of time. You can take a couple of paracetamol or something normally and reduce it anyway if you're going to have one. I know we had it at one stage going in and out of work, but it got dropped fairly fast. The coronavirus self-checker, and this is a questionnaire type thing, which a number of the CDC have developed one. Yeah, I didn't bother putting one up. There's about 9 million of them out there, and from various reputable sources. There is a lot of research, and again, I tried to step back from most putting it up. I've 1 or 2 articles, not a lot. The one thing I would say to you is consider where you're working. If somebody is positive, what is the policy in relation to that? If it's in a clinic that you come back, that somebody who's in that clinic and they're in the day centre for the afternoon or the day with you, is there a policy on what you all do about the other clients and such like, or what is it? And it's something to remember. Have things in mind. Would you benefit from having a coronavirus self-checker in place as the clients came in the morning if you're working in any kinds of group? There are things to consider and look at. COVID, unfortunately, is part of our life and is not, by the looks of it, going away anytime soon. So we need to be able to build it in so that it has the minimum impact on us delivering the best healthcare we can. And that's what I want to do. I want to keep my patients healthy for as long as I can, in the best state I can possibly keep them. And if that's physical, that's planned. Barriers to health screening. Why don't people go for screening? Fear sometimes. They don't want the result. And you'll find that certainly with COVID, we have people not turning up for COVID screening. They didn't want to know they had it. Lack of knowledge is very, very common. And it's very common, particularly, unfortunately, among a cohort of your clientele who have never developed a good relationship with any kind of institution or structure that would be inclined to push this. Lack of education. Again, the people with a serious mental illness particularly have a lower level of education because they've never had the same opportunities. So it is an issue. Socially isolated. Again, look at your clients. And this is the problem. They fit into a lot of these. These actually all apply in relation to COVID. While I know it's not a national screening program, but you can think of it. Fear, lack of knowledge, lack of education, socially isolated. They would sit on all those. Culturally isolated. We've had a problem with that. Certainly in COVID now with some of the new Irish here. But we have the similar problem with our national screening programs as well. They don't know about them. They're worried about them. They're worried about what people will do with the information if they get it and such like. Lack of time, quite common. and a geographic location. If you can't physically get there, and it's grand, and you know, as I say, I live in Laytown, Bettystown. If I get called for breast check, I get called to Navan. If you want an awkward journey, if I didn't have a car, I'd be a long time getting there because there isn't any direct bus line. And that's an example of someone who's quite near Dublin. You know, could you imagine if I was down the country? It'd be even worse, or I'm waiting for them to come. So these are all factors that imply, and so many of them apply to your patient group. And think about those. How can you help? Education, and I'm talking about all the time, and this is where unfortunately we don't see them, but even when they are in clinic or at the day centre, and I know they're starting back with those now, is there any leaflets about it? The GPs aren't too bad, they'll put some around as well, but that you constantly bring people in to talk about it sometimes, it can be useful or helpful. And finally, in summary, we have 4 national screening programs. They're aimed at the population, ideally when people are asymptomatic. They're all free. I'm big into prevention rather than cure. The earlier I get them, the better the prognosis. COVID screening is part of our life. The other thing I'd say about COVID screening is constantly changing. What's being available, what isn't available, will up and down. The research is constantly coming out on this, so it will adapt and change. So these are factors to bear in mind. But the biggest question is, are your patients or clients being screened? And I suspect not the full percentage that should be, and that's what I would worry about. So it's, as healthcare professionals, what we want to do is advocate. They're not going to make a special case. We do, unfortunately, the screening programs do depend a lot on the person coming forward, and I think our clients need a bit of help sometimes to come forward. So that's it from me. I'm going to hand over to Angela now. We'll talk a bit about MEC, and thank you very much. Now, Angela.
Thank you, Sheila. Thank you very much. Okay. To continue on, I know Sheila has went through all of the screening programs with you, and I've been thinking of it with my mental health background on me and trying to find out a little bit more anecdotally from speaking to staff, and also by looking at the literature. I depend heavily on research publications to see what the evidence is there on the use of screening within mental health cohorts. So I don't want to bring you a whole lot of articles, but I just want to bring you some information about what's happening around the world. And this particular article looked at a big population of people who were cervical screening. We mentioned that earlier, Sheila, when you were doing your 4 screenings. And this is a population of women, over 1 million women, and within that cohort they were able to identify people who had mental illness, you know. So it has the big cohort of the general population, and it has the cohort of people with mental illness. And it's able to identify, you know, what the amount of screening that took place within the different cohorts. And interestingly, that's a big study and a big population. So they did find that women with bipolar and schizophrenia were less likely to go for their cervical screening. And if they did, their screening was delayed. They didn't go when they should have. They were maybe a year or 2 down the track from when they should have been. So their screening rate was a lot lower than the general population. And that's why you were saying, Sheila, it's so important that we ask our clients, you know, have they had their cervical smear? Because this gap suggests that, you know, they definitely are in need of, you know, advice, and, you know, this barrier that might be there needs to be addressed either with the patient themselves or maybe with ringing their GP, their physician, you know, because the evidence is there, and it's quite a recent article, you know, 2020. And this is actually this article came from Canada, so it's quite relevant, you know. It's an English-speaking population that we would consider a first world country, you know. So it would be very similar to UK, Ireland, or Australia, you know. So this is what we're finding, you know. So that kind of, you know, that kind of indicates to me that there is a problem with our patients who have chronic mental illness, be it schizophrenia or bipolar affective disorder, that there is a delay in having, you know, going for the screening, and then if you're not screened, you can't treat. Isn't that what you were saying, Julie? You just wouldn't get, you know, you wouldn't get what you need from the screening. So that's really, really important. I looked at more evidence to see. I know you mentioned barriers earlier, Sheila, and your barriers were all about the national screening programs per se, from a general perspective. I was trying to look at it with a mental health perspective, and I was looking at service users and more information about how our service users, our clients, their uptake on different cancer screening, you know. So I was looking for information on that, and I found a very useful article there that looked specifically at a qualitative study on, you know, both clients and professionals, and why or what were the barriers to screening. And I'm just going to go through a few of the barriers with you here now. And again, very similar to what Sheila said about afraid, lack of knowledge, lack of education, maybe socially isolated. Very similar barriers to the general population, but much more information within that, because when you do a qualitative study, you can go in and you can look for, you know, specific reasons why, rather than just, you know, one thing. You can go right down. So a lot of the information was from the clients themselves, was not knowing enough about it, not having the knowledge, not having the education, you know, not being able to be aware of why they needed it, you know. And even the mental health professionals, they were asked, as well as the clients, they were asked. And they also, nurses who were looking after people like us with mental illness, didn't know enough about the programs, about exactly what you've said about the 4 screening programs. And, you know, they didn't know enough about, you know, what age groups and how you apply, and, you know, the usual things that we are trying to bring across you. So there was a lack of that. For the people going for screening also, they were afraid that they didn't understand, the professionals that were screening didn't understand the client, you know, and there was this stigma about the mental illness. And also, again, the diagnostic overshadowing, that, you know, they would see more the illness than the mental health illness as it presented, rather than, you know, the physical illness. There was other barriers around screening as well, to do with time, you know, lack of time, maybe, you know, lack of belief that they could get there in time or be able to, you know, do the screening. Again, additional burdens also, I suppose, to do with appointment times, taxis, book, and getting there, you know. So there was loads of different barriers that was identified, both from the science perspective, from the client's perspective, and from the service provider's perspective. And again,
Sanjeev, Sanjeev has just made the point that when they tried to include, when you tried to include the national screening as on the checklist for physical health intervention tool, there was a lot of resistance to it.
Okay.
Have you had that experience as well?
Probably they have, I'd say, because, you know, people, you know, wouldn't be aware, or maybe, yeah, I don't know. Maybe just type in what you can tell us about that, because I'm interested to learn more about, from your perspective.
Sanjeev would be interested. Yeah. Just who was resisting? Was it your colleagues or
the patient themselves?
Or
yeah,
the national screening, which would maybe on them?
Yeah.
Hi, Sheila and Angela. Maybe I could could explain that. Yeah, if it's okay.
Yes.
Yeah, no, we kind of brought a physical health intervention tool, and we thought it would be good to have the national screening, even to remind the clients that, you know, they can go to their GPR. We could help them to organize that. I think from the medical team, we faced a lot of resistance, saying that if it's on the list for them, that means we are responsible for it. If something came as a, you know, anything, in any kind, the results are, you know, having any problems. So they said, no, we don't want to have, we're not responsible for the physical health, you know, related with those national screening. So we literally have to remove those national screening checklist from that. We only kind of had the metabolic and the basic, you know, blood investigation there, you know, the very basic ones, but we included at one stage, but there was a lot of resistance. And even from the GPs, like, you know, one time, one of the closed-in clinics, you know, one of the staff did the PSA, because the client was, you know, about 60, and she did a PSA test, and the GP kind of sent back a letter to us that it should be only done by the GPs, and we shouldn't be doing any of the national screening or, you know, the PSA, all those tests. So we kind of faced a lot of maybe resistance from different people, like maybe from the medical team.
Yeah, there's a lack of nobody wanting to take responsibility for this, because
it's interesting if as I say, it's the medical team didn't want to take responsibility, and I agree with you. What, you know, it's a contradiction in terms. If you're a medical, surely you look after the whole patient.
Yeah.
with it. Yeah, and we don't have a prostate screening yet, and that's to do with the fact we don't have an accurate enough. The PSA, they feel, is too inaccurate as a test, so we haven't developed we don't have a national screening for a prostate yet, but it's occasionally looked at. We're not going to get for a year or two now. Sorry, Angela.
It is important, though, that we raise this as an issue, because if we have barriers to screening, it means we're going to have higher mortality rates, because, you know, we know that cancer, even we call it a chronic illness, but it's an illness that will kill you. So, you know, if you're not going to be screened, well, then, you know, our mortality rates are actually going to increase even higher. So we should be encouraging the screening. Definitely the 4 screening programs that are free, you know, we should be really making sure that our clients are aware of it, that they got the invitation to go to screen, or that are even registered. You know, if there's lack of knowledge among our mental health professionals, we can, you know, update ourselves quite quickly, but we also need to update our clients to tell them the importance of having this screening. You know, we need to offer them support as well, because our clients aren't like the general population. They do need that extra help, particularly people with severe and enduring mental illness. They definitely need that extra, have enough burden with one illness. I always call this the double whammy. You know, you have a mental illness, but to have a physical illness, or maybe, you know, to be even thinking about screening for cancer, you know, and certainly with the diabetes. Sheila has said with the diabetes, one of the biggest, you know, commonest is the retinopathy, you know, that the eye will get damaged. So they're entitled to a free screen, and they should be having it, you know, the same as anybody, you know, with diabetes. So we do have to kind of give them support about that, you know, educate them. If there's a literacy problem or cognition problems, which many of our clients would have, you know, cognition problems. So we certainly need to be kind of reminding or saying, or, you know, talking about it. The other thing that the article that I looked at, Clifton looked at when she spoke to the clients about barriers, was the one about anxiety. We always say that, and we said that last week when we talked about patients with diabetes afraid of having hypos or afraid of having to have insulin. Do you remember we talked about the anxiety that can occur for them? It's huge, you know. So because it's anxiety provoking, it means that maybe they'll pull back and not want to engage with it, you know. So we have to be talking about allaying the anxieties for our clients when we talk about these screenings, because, you know, it is worrying. It is worrying, and you're right, and the waiting time for the results is worrying. So we can do a lot around helping, and I feel I have a moral responsibility to do this. And I think mental health nurses are beginning to realise, you know, that we can help clients more with their physical health by offering advice. We're not experts, but we can direct them to the right places. We can show them, you know, where to register for a screening programme, or help them make that phone call if needs be. So we can offer a lot. And ultimately, remember, we're there to help and to save lives. So this is one of the ways that we would go about it. I think it's really important for us. You know, so we do talk an awful lot about screening. We spent the last half an hour nearly talking about the importance of screening for the cancers. Also, we talked about, you know, the importance of, you know, intervening over the last few weeks. And when I talk about intervening, I mean, okay, we know somebody has a chronic illness. What are we going to do now? And there is, what Sheila mentioned earlier, there is a package out there, if you like to call it that. It's called MEC. It's really a skill that people have. And I know as mental health nurses, one of our skills was always using a therapeutic intervention, which we call the therapeutic relationship, really. But it's more than that now. It's more like motivational interviewing, that we're using that time effectively to talk about something that's really important, whether it be the mental health, you know, of how is somebody's mental health, or now maybe talking more about their physical health. So we're going to talk a little bit about how MEC can help, if you like, how making that contact. When you come in for your bloods, if you're a closeted patient, you're sitting with the nurse, you could be there for 5 or 10 minutes, and it's a time to engage in maybe more conversation about health. Same if you're coming in for a depot injection, you just don't walk in and get your injection, walk out again. There's time there that the mental health professional can use that contact time to talk a little bit more about chronic disease management or prevention, if you like. So the core aim, I suppose, of this MEC is disease prevention. That's why we call it a health promotion sort of thing, you know. And the things that we're really talking about preventing for our clients and the interventions that we're going to talk about are usually around things that can make you very sick, like cigarette smoking, you know, if you're smoking 40 cigarettes a day, or harmful alcohol consumption, or for somebody who's completely inactive, you know, and has a BMI of 40, we know that that's going to lead to huge problems with chronic illness. So, you know, we might even talk about, you know, maybe eating or diet or anything that's relevant to that particular client. We're not going to burden them with everything they want there, but it offers opportunities over many weeks and months every time we meet to say, you know, how did that work for you? Or, you know, there's an opportunity there to make that contact count. And that's what MEC is about. It's really about how we use it. When we spoke on week 1, we talked about metabolic syndrome and what was it, and it's a combination of risks that come together, you know. And remember, we mentioned 5 different things like obesity, high blood pressure, high blood sugars, diabetes perhaps, and then high cholesterol, you know. And we talked about how they come together to cause this cluster that'll make the patient end up with a chronic, you know, physical illness. So, you know, metabolic syndrome is really a chronic physical illness, and that's what it's, you know, termed as now. But we also, when we talked about that, we talked about preventive things that we can do to prevent metabolic syndrome, or to lower risk, if you like. And the lowering risk, see, this is why it fits so well in with MEC, because to lower the risk and to offer an intervention, you're just talking about healthy diet, you know, healthy weight, physical activity, reducing smoking or eliminating if possible, and managing somebody's stress and anxiety. So the interventions for metabolic syndrome are actually the interventions exactly that MEC, which is the national program for intervening with, you know, making every contact count, are exactly tailored to what we need as mental health nurses to sit together. So, you know, we were so lucky that we came across MEC and how MEC can sit in with the prevention of, you know, and the treatment of metabolic syndrome. So the two kind of sit side by side. And I think it's important to realise that when we're dealing with patients who have all these risk factors, that we don't ignore them, that we, you know, work towards, you know, maybe healthy diet, exercise, things like that. We can talk about it. You know, we can open up that dialogue, if you like. So MEC is not going to be something that was going to go on forever. We can only do it over a short period. So it's called brief advice. You're not going to bring somebody into a room and spend 2 hours offering the intervention. You generally do it over 10, 15 minutes of your regular clinic appointment, if you like. And focus always on the back of your mind. It's about disease prevention, you know, and we know as mental health nurses, we do spend a lot of time looking at mental health, but now we also incorporate physical health into it. And it's an opportunistic time to bring around the conversation about diet, exercise, smoking, and so on. And it's something that we can use in our interventions. And I know they call it, you know, motivational interviewing, and that's all it is. That's exactly what it is. And we don't have to have special training. I mean, we did the course when it was introduced in 2019, I think, before COVID, 18 maybe, and we had to go as health professionals to learn how to deliver MEC. But really, for any nurse that's already out there working in with clients, you already know how to build up therapeutic interventions with patients. So it's not like rocket science. You can pick it up quite quickly, and there are tools that you can use to deliver your brief advice and your intervention, you know, like handout tools that we've always had over years. So the core 4 things in MEC, and exactly what I said, that this is how they work so well for metabolic syndrome, because the 4 core themes are physical activity, looking at the whole area of obesity, because we've got chronic obesity in the world, and WHO are very worried about obesity by, you know, the next 10 or 20 years, apart from COVID, they have a big concern about obesity. And the last 2 things that are concerning for MEC would be alcohol consumption and the use of smoking cigarettes. So these are things that fit directly into our intervention for somebody who may have metabolic syndrome, obesity, high blood pressure, high cholesterol, you know, all those things kind of fit well with the advice we're offering here. So we need to kind of fit MEC in with our physical health interventions, and that's our intervention, you know, because the whole area of screening is so important. But if we don't intervene when we find a problem or an issue, if we don't say, look, these are the things you'd have to do, well, then we're not offering anything. You know, screening is no good really without intervention. You wouldn't go to a doctor and he'd say, oh, now you have diabetes, good luck. You know, you don't do it like that. You know, you have to have some intervention, and you have to have more knowledge about, you know, the illness that you have. So for that reason, it's very, very important. I have to say I've found the HSE have improved tremendously in the last 3 or 4 years. The websites within the HSE now are, you know, more detailed on mental health support. Most of you are probably familiar with this particular website that looks at physical health supports for people with mental illness. There are lots of additional pages that can be used, and most of them contain all of the information that we might need for helping us do our interventions. You know, so it's really, there's been a lot of work put into this in recent years, and I certainly would encourage people to look at the mental health services and the physical health supports for people with mental illness that are contained within these pages, okay, within the HSE website for mental illness. And one of the ones that's mostly interesting for me as, you know, an educator, I suppose now, is to talk about the importance of the physical health screening on admission, the very nice document that they provided for screening on admission. It can be used in the community as well, because most of the information within it is it opens up the dialogue to ask the question about either exercise or smoking or alcohol, but it also offers an opportunity to say, I intervened, I asked a question and I offered advice. So from that point of view, the pages within it, like for instance, the page there on tobacco use, it asks a question, because I know it's when we're gathering data, we're trying to, you know, when we're doing metabolic screening, we don't always ask if the patient's a smoker, or we don't often ask how much exercise they do every week, or we don't often know, for instance, you know, what other medications they're on. So it gathers a little bit of information on smoking use, and we know that smoking is a contributory factor to chronic illness. It's a huge one. So we get to find out if patients smoking occasionally or all the time, or if they're even vaping or whatever they're doing. And then, as well as getting that information, there is a chance of an intervention. It's built into the document. You haven't even to go to look for it. The intervention is, you know, that you signposted the patient to the HSE website, or you refer them to the quit, the smoking. You know, there's opportunity there to talk about it. And this might only take a few minutes, but there is an opportunity there. Obviously, if the service user isn't interested or declined, you can say at this time in your, you know, little report, you can say at this time this was talked about, but you know, the patient wasn't ready, or you know, whatever. So you have your intervention as well as your screening going on there all together. So that's hugely beneficial, and that's exactly what MEC is about. It's about asking the question and then providing some sort of a signpost or an intervention, brief and all as it is. You know, it's not, it's a 5 or 10 minute thing. It's quite brief. There is also a page on the screening document about alcohol use, and that's good too, because you know, we mentioned, Sheila mentioned about alcohol use, and you know, all the different cancers we can get from alcohol, you know, right down from esophageal, stomach, bowel, you know. So important to know about the use of alcohol, you know, if clients are drinking, how much they're drinking, so you're kind of getting that sort of information. And then you can talk about, you know, your intervention, the benefits of maybe the risks, of course, of long-term use, the benefits of cutting back, you know. So there are helplines as well that can be recommended, you know. So we have certain interventions there that can be used. And again, if the patient's not interested in talking about, we can, you know, absolutely, you know, for our own benefit, we can say this was spoken about, the patient's not interested this time, but at least we've asked the question. We've made the connection between, you know, the screening and the intervention. So that's really important. The next one, of course, for anybody with metabolic syndrome is always going to be central obesity. That's why we do the measurement tape. And again, BMI is linked with that. So BMI is over 30, we're concerned about that. So if your client is being screened already for metabolic syndrome, you will have done a height and weight and hopefully worked out a BMI. So BMIs, you know, they're coarse enough, really. They're not as good as the tape measure around the waist, but at least they'll give us an indication, you know, if the client is gone over 30 or if they're heading up to, you know, morbid obesity. So there's interventions as well for that, you know, that If they're underweight, then we would send them to, some sort of a nutritional screening test that we can do for that. Healthy weight's fine, and how they're managing it. And then the different interventions for people who are overweight or someone with obesity. So the brief intervention might be about the benefits of, healthy diet, fruit, fiber, so on, strategies that might help them with that, so we can do that. If we've got someone with, morbid obesity, we certainly will be looking at referrals for, more assistance from dietetics and dietitians. So, we can look for that support from the dietitians, department. So we're kind of trying to get an intervention in place. Again, if the service user isn't interested or declines, well, then we'll mark that off and we'll say, yes, we have spoken about this, but at this particular time they're not interested. But it doesn't mean you can't return to that at another time. It's not saying that it's, closed off. This area of brief intervention with motivational interviewing can take place again and again over a period of weeks and months and years. It's not the end of it all. And the one that I suppose helps us greatly as well now with intervention is the physical activity. So we're not going to be intervening until we know, how inactive is our client. So they don't always declare exactly how much activity they take. They might say they do a lot more than that might change. Some people say, oh, I do 30 minutes a day. And then when you drill that down, well, it might not be 30 minutes. It could be only 5 minutes going to shop and back. So trying to get the adequate information about how much exercise they're doing, we would encourage maybe, according to HSE land, 30 minutes or more a day, so we're trying to find out if it's adequate. Does our patient get that much in, and space it out over 3 or 4 days to see have they adequate or is it inadequate. For somebody with chronic illness, it can often be inadequate. So maybe the brief intervention there for MEC would be some benefits of what physical activity can do, and maybe talk about the mental health benefits of physical activity. Support websites, Let's Get Active, maybe, things like that would be more beneficial to them, or maybe set them up with information about a group in the locality or whatever you can. If they're not interested or decline, always document that, because it's important that you did offer the advice, that's your intervention, that you offer the advice. It may not always be taken up, but you could come back to it again at a later stage. You could say, did you think about what we said 2 months ago or a month ago? And do you think, maybe the weather's nicer now for going out, so you could get around it that way. We do that all the time, because everything we say is not listened to and people forget, so we have to revisit it. So there's some of the things that will help. I just want to mention a little bit about the Mental Health Commission as well, because, apart from us offering all the advice and interventions, we have an obligation and a statutory obligation towards the Mental Health Commission, who are our overseers, if you like, with the rules and regulations of the Mental Health Commission. We have Regulation 19, which is specifically around, the whole area of physical health care within mental health. So there are checks, and when they do their site visits, that this is something that they do zoom in on, and they look at the Regulation 15. They certainly look at your ICPs, your individual care plans, and part of that individual care plan may well be something to do with general health if a patient has already got a chronic illness. So they do more and more look at this. And my experience of speaking with Dr. Susan Finnerty in the Mental Health Commission is that she's extremely interested in this area, and she's been disappointed over the last few years. She certainly did an audit in 2019 of high support hostels, and she was disappointed to find that the documentation wasn't what she would have expected, and that they were not compliant on Regulation 19, and in certain areas Regulation 15 as well. So it is important that we realise that this is something that's taken very seriously by the Mental Health Commission. They already have another document out, the most recent of the documents, and these documents are certainly going to be made available to you, and this one's worth looking at because it specifically, since Dr. Finnerty has been extremely interested in this, she's gone back and back. So she has written a new report on physical health for people with severe mental illness. It is on their website. We have it also, the RCSI and the PNA, thank you for sharing it, will make it available to anyone that wants to look at it. And again, the stats are there, and they're well referenced as to who did this research. And again, look at the amount of obesity, look at the increased risks of somebody with either schizophrenia or bipolar affective disorder. You can see the risks of obesity, smoking, diabetes, hypertension, hyperlipidemia, and metabolic syndrome. And I'm shocked at the metabolic syndrome rates, because we would have said, 25 to 30% more. Look, we're right up to 37 to 63%. So that's very, very high. So they're increasing the risk even more and more, So from that point of view, it's a considerable concern to somebody working with patients with chronic illness of the amount of people with schizophrenia, and people bipolar aren't exempt either. They're certainly increasing cardiovascular risks within those populations. So the evidence is there. They're not forgetting about it. They're certainly zooming in on it, the Mental Health Commission. They're well aware of it. So I think this is going to be something that's going to increase more and more over the next couple of years for mental health nurses. It's not something that we're going to forget about. It's going to be brought to our attention more and more. Mental Health Commission are also looking at, how we can manage COVID-19. And, they have, because we were looking for information on this as well. So they have produced a good report there on supervising, monitoring and supporting people, Irish residential mental health service users. And from my point of view, we do talk about this, the space and the not sharing bedrooms and the ability to isolate, and staff training and PPE and, the right ways of managing it. But in the middle of that document, they talk an awful lot about the patient's profile, the age of the patient, the underlying medical conditions. So they know that the people with underlying medical conditions are a bigger risk, completely huger risk to COVID than the general population. So we know within our mental health settings that we have an awful lot of patients with metabolic syndrome and with other, chronic illnesses, which we've often talked about already. So, the risk factors there are huge for mental health services. So I'm glad that the Mental Health Commission are taking this seriously. This is a very good read. I would advise, if you're concerned about it and you're working with people with chronic illnesses, this is one you might look at, because it kind of gives you the facts. They put a lot of work into it, and there's a lot of facts there that we could take home, messages for us that would help us in. And I think Sheila, my colleague, is dead right. I think COVID-19 is going to be around for quite some time. And from that point of view, we're not going to be able to eradicate it, but, we're going to have to try and manage it, within our mental health services, either in our acute units or in our high support hostels, or even in our day services, that there's going to be that risk there. But do bear in mind, the patient's profile will, and we talked about that last week when we talked about the age, the increasing risk with age, and now the increasing risks with the underlying medical conditions, and sure, that we hear Dr. Tony Houlihan on the television most nights talking about who ends up in ICU in high dependency. It's generally, more or less people who have already got underlying medical conditions. So we don't want our clients, to be exposed to any more illnesses than they have already, unfortunately, over their time have. So it's really important that you look at that. So from my point of view, thank you for staying with us. Thank you, Sheila, for going through the 4 national screening programs, which we know are free of charge. And again, prevention is better than cure. So that's our aim, to talk about health prevention. Make sure your patients are aware of the screening programs, and if they need help, for God's sake, do help them. I mean, that's our role as caring professionals. Remember that metabolic screening is there already. We know how to use it. Remember that if they have 3 out of the 5, we need to offer a health intervention, and I would encourage you to think about MEC. It's just a little talking opportunity and motivational interview, and that you're talking for that 5 to 10 minutes when they come in to visit you, or when you speak with your patient, even if you're doing a home visit, whether they're 80 years of age or whether they're 20 years of age, the opportunity is there. It's for all, and certainly my take home messages from this would be COVID and underlying conditions, particularly chronic physical illnesses, so it's one that we just, it's very worrying really for us to think that our clients are so vulnerable. They're not really aware of it at all, I think, a lot of the time. So, we are. So, try and keep that message alive if you can. It'd be really important. So we have websites there, and we have supporting documentations. And I thank you for the Royal College, who have offered to, be kind of a, if there's questions or if there's help you need, that they can come back to us, both Sheila and I, we're not experts, but we do try to, you know, look at the literature and look at the evidence to bring it to you, to make it easier for you to follow. So, you know, we're hopeful that over time, if there's any questions that you need, or, you know, information or articles, that you let us know. And thank you for staying with us. And if there's questions, I can't see the question page, but if there's questions, we would happily take them now.
Thanks, Major. Aisling raised a point in relation to when Sanjeev was talking there about the challenge of mentioning the screening programs, and Aisling did want to raise a point in relation to that. She said, just to make a recommendation or chat about regarding this, the content of health policy Sláinte Care, sharing the vision. So just give Aisling a chance there to come in.
Thank you. I because of my sound, I hope you can hear me. I've taken off these because of the buzz issue. It strikes me in terms of the MEC and all of the useful tools that both of you have shared with us. I'm aware at policy level, because I'm at the sharing division table, this dotted line, if you like, which I have a problem with, but the connection between sharing division and Sláinte Care is constantly being raised as part of policy and the implementation of sharing division. And without getting into it too deeply, I suppose, it jars somewhat with me where they kind of put mental health in as part of sharing division as almost a year later as an afterthought. But now we're trying to combine the new mental health policy sharing division with Sláinte Care in terms of access for all, in terms of health services, in obviously physical health services. And in that space, screening doesn't come into this really. It's not even mentioned, I have to be honest with you. So I think there's an opportunity perhaps for somebody like myself who's sitting at that to maybe have a discussion at the policy level as to how they're integrating screening in whatever way we're talking about screening, whether that's us intervening as part of the screening or at least signposting as to where that's been missed, because there is a disconnect. So it's not being looked at really. I'm not saying that it won't be, because sharing division is in early days. It's only in its year 1 of implementation, but it's something I think I'll raise at that forum as to how Sláinte Care, if we're being true to the policy of Sláinte Care with sharing division, then why is this lag in between? Because it was mentioned by a colleague, and very rightly this morning, in terms of resistance, and Angela, you went through it too, in terms of resistance locally or resistance in the medical field as well. And if we can't get it right at policy level, you know, further up to try and distill down, then we're in trouble. And it was disappointing to hear that. And thank you for your comment about the resistance that you encountered when you started looking at screenings, or I kind of only came in on some of it in terms of where you found the resistance, but my understanding was with colleagues and indeed with medical personnel. So like, that's a cultural and mind shift that has to happen. You know, we have a national screening office now, apparently.
We have.
So that's a national position. Sharing division is a national position. Sláinte Care is a national position, but there are 3 national positions sitting.
The integrated concept hasn't hit them yet.
No. I certainly think I will try and do something about that.
Aisling, I must thank you for that, and the idea of you doing that is wonderful. I think it's something, as nurses particularly, we're not aware enough of the impact we can have in contributing to policy. Now, Sláinte Care, and I thought I was very reserved on it, and Angela would know this, as you can end up lecturing on various topics at times in work, and I did have to, I was working with health policy at one stage, and it caused me to chase up on Sláinte Care. And I looked at the committee that had put Sláinte Care together, and it was a committee made up of TDs. And I was going, eh? And then I went to see, and they did, in fairness, they did look for input from the experts. So they went to healthcare professionals in Trinity, and obviously economic professional. And I was going, and where did they ask anyone on the ground? And they didn't. If they had, they would have been aware of the issues that we have, that you've experienced, that Sanjeev have experienced. There is quite frequently an opportunity to input to policy. And it's something, again, we need to look at. It'll depend what policy is being developed. At the moment, it's in relation to transport in Dublin. If anyone wants to contribute to that policy, you can submit. I know we did it when the Commission of Nursing was coming on. We were much more focused on that. I know a number of us would have contributed then. But the various policies are being developed. As an individual, as a healthcare professional, you have the right to contribute. And that's something we need as healthcare professionals to keep an eye on, to make sure we do make our voices heard for the sake of our patients. And that's what we have to do. And as I say, the thought of Aisling, you bringing it to the table, great. But the more we do it, the better. Yeah. You know, everybody, the more people who do it, it's like the MEC. If everyone keeps mentioning that you need to look at smoking or you need to look at your weight or things like that, the message gets through, and it's the same for us with it.
But personally, just speaking as somebody who will bring something to the table, sometimes listen to and sometimes not, I might add, but there's nothing more valuable to me, and Angela know this, because she's been here and done that and been where I have been. But you know, there's nothing more useful than you can give an example of an issue, because it grounds the groom into where it is you're coming from. Sometimes you come, you know, I won't say I'm guilty of it, but when you come representing an organisation, doesn't matter what the organisation is, it's just, oh, you're representing the organisation. But I mean, if nothing that I learned from Angela actually and Des over the years is a little bit of storytelling tends to get the people in the room, you know. And so I'm very grateful and thank you for the example. And I may come back to you if you don't mind, in respect to it, because that's the reality on the ground. I mean, you know, that's where the issues lie. And if we can't distill that back up towards the system, then we're guilty of the disconnect in a way.
Yeah, and I would say to practitioners out there, you know, if somebody is putting a barrier in your, you know, trying to prevent you from doing something you know is right, I always say, show me the evidence. So show them the evidence, you know, tell them why this is important, show them the mortality rates, show them what chronic illness is doing to our clients, you know, say, you know, this is so important, you know. So, you know, I think we do need to, exactly what you're saying. Tell them the story, but also maybe show them the evidence, because you can't rebuke, you know, a huge, you know, lot of evidence like the literature reviews and, you know, the evidence that we see in reports. Mental Health Commission aren't writing those reports on a whim. They're employing a lot of people there to search for evidence. So, you know, use those documents if you can, you know, to show the evidence is here. You know, we can't disagree with evidence, can we? You know, if we do, there's something wrong with us, you know. So, you know, I think use, you know, for practitioners out there, I say, find the information, get the articles, have a look at them and say, this is why I'm doing it. Hold it up like a red flag, you know, and that will make a difference, I believe. I really believe it will. You know, what would you think, Sheila?
I think, yeah, and we don't appreciate the voice we have, and we are all much better qualified now. We all have experience of research, and as Angela says, of using that to support. So I'll tell you my story and I'll say, and this is not unique, because if you look at the study from X, Y, and Z, they're saying the same thing. And that's what we, as I say, we can, anecdotal evidence isn't enough on its own. I can give you a touching anecdotal story and I will back it up with the research. And that's what we can, and we do. I don't know what it is at times, we don't do it enough, I think, but we need to be pushing it. And as I say, it is great that you can bring it to the table, and that's what, but I want, you can imagine if lots of other nurses were also telling that story to various people who were also coming to that table, then you'd have much more support and agreement much quicker. And that's what I would like to see. We all have a voice, let's use it, because like Andrew was saying, our patients will die quicker. They will. Not only that, they'll have a miserable quality of life while they're getting there, and that's why I want to keep them healthy. You know, I want to use the tools we have. Life can be challenging enough, but we have, and I give out a lot about us certainly, but Ireland is not a bad place to live, and we don't have the worst health system by any means. So let's use the good bits that we have and use them to keep our patients and clients healthier and happier.
Thanks.
That's how I feel.
Thank you. Thank you very much. Okay, so that's our roundup for this session. I hope you get some benefit from what we're talking about, and perhaps we'll meet you again next year. We don't know yet, but hopefully we'll be able to offer something new or something more. What you might require, more information, whatever. We'll be certainly willing to do that. Thank you, Aisling.
Thank you, Angela, and thanks, Sheila. And on my own behalf, and on behalf of the college, I know Catherine couldn't join us today, but on my own behalf and that of the P&A also, I want to thank you both most sincerely. It has been a really great 3 weeks. I appreciate the amount and volume of information you've shared, but also the practical side of all of this. So you make it less overwhelming and more accessible, which is the whole purpose of our webinars, I guess, in many ways. And indeed, the matter and the issues you've raised are hugely topical right now. They have never been more topical, let's face it. And you know, a lot of this is, whilst I understand that the frontline things are tough, things are, you know, grappling with issues, but I believe actually when we pause for breath again and we reflect on some of this, these presentations, this information is going to even resonate more. Sometimes when you're in the height of the storm, it's like it's coming at you from all sides. So I do believe you most definitely will be back to try and try and distill this information again when it's a less frenzied environment, I should suggest as well, because that's that's a bit more applicable to learning anyway. At the same time, as I've said earlier when I opened, we have had a lot of contact from people looking for these presentations right now. So the accessibility again is very important to us, whilst colleagues and members are in this particular, I suppose, pandemic and service delivery. So it's not just that, it's the long term also. So indeed, you'll be welcome back for sure in the new year. And hopefully we will be maybe easing our way into a 2022 with less frenzied issues. But on my own behalf and that of the P&A and the RCSI, I want to thank you both most sincerely, and indeed to all of you who've joined us for these webinars. I have put in the chat that due to technical difficulties, as I said from the outset, Anya very kindly has offered to send today's recording to those who've previously registered, along with the slides and the documents we mentioned earlier. This particular recording will be going up fairly shortly anyway as part of the RCSI P&A suite for this particular autumn-winter webinar, so they will be available on our websites as always anyway. But in the meantime, I want to wish you both very well. Keep well, all of you. Keep safe.
Keep safe.
Mind your mental health in all of that too. And thanks very much indeed.
Bye-bye, everybody.
Bye,
Bye.
everybody.
Thank you.
Bye now.
Bye.